Welcome, everybody. So I'm Peter Handtevy, and I'm so excited about today because the two gentlemen that you're going to meet today, hopefully some of you have met them already because we've done some webinars with them. But these two guys are they're like, if there's a tip of the spear, they're at the tip of the spear with respect to all things EMS, but especially cardiac arrest. If you remember in the past, these guys are very good at using data to evaluate how their patients are doing, how their outcomes could be made better. And then they've taken it to a whole nother step, which is the cusp of today's webinar, which is we have patients, we get ROSC on them, adult or pediatric, we bring them to the emergency department, and then everything just falls apart. I could tell you personally that I've been on the back of the rescue, we get into the emergency department, and I just see it there. It says here, medical director. They see me walking in. We have a patient that just got pulses back, and literally everything falls apart. And what Mike and Adam are going to show you today is something that all of us should copy. I know they're big believers in R&D, rip off and duplicate, but you will truly be amazed by what Mike and Adam have done, the process by which they've actually implemented it, and you'll see that their outcomes have just ballooned. So if you follow your cardiac arrest outcomes, which I hope all of you do, the difference between having a single digit outcome of survival, let's say you're at 8, 9%, to let's say getting to 12, 13, 14%, could be just, let's say 2 or 3 patients, believe it or not, if you look at the numbers in your community. And what you're going to hear today will help you get those 3 or 4 or 5 patients additional back to life, neurologically normal at your agency. So today's topic is the handoff. I don't think you'll have ever seen a webinar or topic on this before because it's brand new to everybody. And so without any further ado, introducing Mike Humphrey and Adam Perret from Lethbridge Fire and EMS. And Mike and Adam, welcome and take it away.
Great. As Dr. Handtevy said, welcome to the final 10 feet. So some of the things we're going to talk about is mastering the adult and pediatric ROSC handover. So as mentioned before, my name is Adam Perret. I'm the medical training officer for Lethbridge Fire and Emergency Services. And a few of the things that I'm responsible for here in Lethbridge is all medical training that goes out to our fire departments, any sort of program development, implementation, equipment change, that sort of thing, all runs through my office for all the changes. The other thing that it does is I'm responsible to ensure that all of our members receive their Con Ed credits and ensure that everything is in line with licensing and everything they need to continue on their careers.
Hi, everyone. My name is Mike Humphrey. I'm the EMS operations officer here at Lethbridge Fire and Emergency Services. My main role here is to identify issues, trends, concerns within healthcare, within our community, and make sure our paramedics have strategies in place to deal with them. I also take all the complaints. Not that we got a lot, but I'm the tip of the spear for that.
Just so everyone knows, we do have no conflicts of interest here. Some of the things we're going to be discussing today are our experience with Lethbridge Fire and Emergency Services and Zoll X Series Advanced, how we've integrated that in with Zoll Online, and specifically the Canadian version. I think in the United States, it used to be called Zoll Online Advanced or Advanced Case Review. And so that is, there's still some name differences there. We are aware that there's several other software options out there. We just don't have a great working knowledge of all of those. But the things we're going to talk about today, you can take and take the key points no matter what software you're using, no matter what data you're collecting, because the key is really about collecting the data and using it in a positive way with your membership. And any pictures that you're going to see during this presentation, we've been given permission to use these pictures, or we've been asked to keep people confidential. And so we've been able to facilitate that request as well. And so what we're going to talk about today is our program, what happened here in Lethbridge. That's going to lead us into some of our initial trends, a protocol change, and then finally into the clinical handover side of our business and what it is that we do with that. And just so everybody knows, Lethbridge, Alberta, Canada, we're the 3rd largest city in our province, and that's us there, right on the southern tip of Canada. And so we're about, you can kind of see it there, the US-Montana border there. So we're about an hour north of Montana. So that's kind of where we're situated. We are an all-hazard, fully integrated fire service. We have roughly 190 frontline providers. 150 of those are advanced care paramedics, 29 primary care paramedics, and another 12 or so that are medical first responders. And what I'll tell you is that all of those medical first responders at one point in time were either in advanced care or a primary care paramedic. In 2023, we did just under 24,000 calls with an additional 3,000 fire calls on top of that. And the information that we've collected is we've collected since from January 1st of 2022 until December 31st of 2023, we've 218 adult cardiac arrests, and we were successful in getting about a 31% ROSC rate. And so we have almost 100% compliance on all adult and pediatric cardiac arrests that get uploaded to case review. And then Mike and I review every one of those. Today, because we're talking about the integration between EMS and hospital staff or hospitals, I'll let you know this is our hospital that we transport to. It's the Chinook Regional Hospital. It is a level 3 trauma center here in Alberta. It's a 309-bed facility that includes maternity, pediatric, psychology, and they have 27 funded emergency department treatment spaces. You see a rough average of about 57,400 patients last year. And we just learned this morning that about 20% of those patients come in via EMS. And so we provide them quite a significant chunk of their business comes from us. And
Adam, what was that? What was that white substance? What is that?
Yeah, we wanted to add some Canadian in for everybody. And so you can see the white stuff by the no parking signs. It's on the ground in the background. I know a lot of you are from southern states and down near Florida. And so no, Peter, that's not white sand beaches. That is snow, and it's a much different substance.
I can tell you that in Miami, when we see white powder, it's definitely not snow.
Yeah, no, not at all. And so where did we start? So this is kind of the precipice for what Mike and I did. And so in October 14th of 2021, we started looking at our cardiac arrest program. And so here this was a 79-year-old female who had a witnessed cardiac arrest while in a private residence. This had our standard response of one fire apparatus and one ambulance. Our fire apparatus was on scene at about 5.5 minutes after the 911 call. And our nozzle person was sent into the house immediately to start CPR and to ensure that it's an actual cardiac arrest. The rest of the crew gathered the kits, and about 40 seconds later, the ambulance arrived. They found the patient located on the ground floor on the kitchen, and they were actually in fact a bystander or in cardiac arrest with no bystander CPR. And so initially, the patient was found to be in a PEA rhythm. And you can see here that's what we're seeing in this top section is their initial rhythm. They started down the PEA algorithm, and iGel was inserted. Accuvent and end-tidal CO2 was attached, and we'll talk a bit more about Accuvent later. IO access, epinephrine, and several rounds of CPR, and then they get a pulse back. And sorry, that's what you see in that top line, is that's where they go from being pulseless to having a pulse. So as our crews were starting to kind of get this patient ready to go, they noticed that they were going into a VTAC rhythm with a pulse. And so they actually cardioverted 2 more times. And that's what you see on the bottom line there is the synchronized cardioversion right here. And as that progressed through, the patient then went into a VTAC, a pulseless VTAC. And you can see on that top line that there was another defibrillation that happened then. And they ended up getting a second ROSC back. So when they were doing that, again, they're packaging their patient, and our crews noticed that patient went from a strong pulse of about 100 beats per minute and started to rapidly decrease in the pulse, getting weaker and weaker and down to about 45 beats a minute. So they aggressively started to treat with transcutaneous pacing, as well as a norepi infusion. And that's what you see on the bottom line there is that was the initial part of the pacing. And they were able to then maintain a blood pressure and keep that patient stable throughout the rest of the transport. And one of the things that we said is that this was with no training. This is a station level event. This is that standard ACLS scenario that actually doesn't happen all that often in real life. We're really good at running asystole codes. We're really good at running VTAC and asystole, but the bouncing back and forth. And so when we met with this crew, we had a PIA with these individuals. That helped to define what our high performance CPR system was going to look like. And we said if one of our crews is able to perform at this high level, then every one of our crews should be expected to perform at that exact same level. And one of the things that we did is we stole the roles and responsibilities function. So we took that bit of stuff that we have on the fire side, where if you go to a structure fire and you ask anyone who works on a fire apparatus, hey, you're going to a residential structure fire, what's the first 5 things you're going to do when you walk in, when you get off the truck? Nobody's talking, nobody's asking each other what they need. Those roles and responsibilities are defined, they know what they are, and they are rehearsed and they are practiced over and over and over again. And so we said, if we can do that on the fire side, why can we not do that on the EMS side of things? And so this is what we did, is we have defined roles and responsibilities. We've built this out from a 2-person, so a standard ambulance response time, a 4-person, which would be our standard fire apparatus, up to a 5 or 6-person response, which again is what most of our cardiac arrests end up having here in Lethbridge. So the nice thing about this is no matter what apparatus you're on, no matter what role you're filling that day, you know what it is. So if I know that I am rescuer number 4 that day, then I know walking into every cardiac arrest or every serious call that my job is the airway. The only thing I need to concentrate on is the airway. I don't need to worry about, am I going to do compressions this day? Should I run the monitor? I know what my role and my responsibility is in advance of that. And so that really drove our program, and we started to see this greater increase in ROSC. And we started to see more and more of this happening. And that leads us into what we first noticed. And go ahead, Mike.
Yeah. So in late 2021, we committed as a department that we were going to give performance reviews on every single cardiac arrest, usually within 24 to 48 hours. And really in doing that, we started to see some patterns in patient pathology. And so this next slide here, over the next 2 slides, you're going to see 11 patients. And so one of the first things that we notice is that about 50% of the time we get a ROSC, that patient is going to be hypotensive. And if that patient is hypotensive below 90 systolic, we realize that there was a 100% chance that they're going to have another cardiac arrest, usually within 2 to 9 minutes. And so what are you looking at here? Well, each one of these cases, each one of these colored bars is an individual event summary, and where yellow is CPR, purple is ROSC, and then yellow is CPR again. And that represents a rearrest. What's super interesting is that all of these charts here, when we read the PCRs, they all read the same. We got a ROSC, we quickly packaged our patient up, we moved him out to the ambulance, and we started CPR again. And so that was our initial trend. We're like, oh, geez, that's interesting. And then go to the next slide. These 4 patients were hypotensive, but they got an early vasopressor from the crew before they actually left the scene. And I think when you kind of compare and contrast the last slide with this slide, is that we have a much longer ROSC section. And so we started looking at, okay, well, what is our actual protocol right now, and how long does it take to implement? Now, this seems a little bit confusing, but this was our past protocol to deal with hypotension post-ROSC. And so what you see is basically on the left slide, did you get a ROSC? Yes. Are they hypotensive? Yes, they are. You jump over to the right slide there, and basically the protocol is, or the guideline is 500 mils normal saline, PRN to a max of 2 liters, and then a mandatory online medical consultation for a norepi infusion. Well, what we realize is that takes much more than 10 minutes to actually do all that therapy. And if we go back to our patient pathology progression, the person rearrests usually between 2 and 9 minutes. All of a sudden, we got a problem here, is that our protocol doesn't actually meet patient pathology needs. And so we brought this to our medical director, and he really empowered us, Dr. Orr, he really empowered us to make a protocol that was implementable within 60 seconds. So we have, just like we showed, we have position and function when we have high performance CPR, we have position and function and strategies for when we get a ROSC. So within the first 60 seconds of a ROSC, we need a 4-lead, 12-lead, full set of vitals, and a complete secondary survey. And if that patient is hypotensive, our members must intervene. And we created a push dose epi protocol. So push dose epi, for anybody that's unfamiliar, is you take your cardiac arrest dose epi, you dump out 9 mils and then you drop 9 mils of normal saline, so you're at 10 mics per mil, and we're going to give concurrent push dose epi with fluid as a bridging mechanism to get over to norepinephrine. And so after we implemented, this is what our hypotensive ROSC patients look like here. So you can see that purple section, that ROSC section, is much greater, and then our rearrest rate dramatically dropped. And so you can also see that blue. So yeah, yellow CPR, purple is ROSC, and that blue section is mechanical CPR, which the auto pulse, which we implemented. But you can see that yes, we do get some rearrests. It's not push dose magic. But you can see that our sustained ROSC is much longer. And so our rearrest rate was about 47% and arrival to ED with a pulse. So it was about 50%. So you can see really, if you rearrested in the field, you never showed up to the hospital with a pulse, very rarely. After we implemented this, our rearrest rate improved to 23% and our arrival to ED with a pulse increased to 88%.
Sorry, Mike.
So what's interesting is we've been doing this protocol and this guideline for about 3 years now, and this is the new provincial protocol that just came out. And so you can see that, is the patient hypotensive? Yes, we're going to do concurrent fluid and push dose epinephrine as a bridging mechanism to norepi infusion. And then the slide on the right is our pediatric ROSC protocol. And so, yeah, it's basically the same thing. We're going to give concurrent fluid with epinephrine as a mechanism to get over to an epinephrine infusion. So that actually just went live in April here of 2025. And here's an example of an operational performance of exactly what we're talking about. So this is called vital signs trends, and we get this off our defibrillator data. And the first, the vertical axis is the vital sign value, and the horizontal axis is time. And so on this, the vertical blue line is right when they got ROSC. The dark blue line that's going horizontal across stream, that's heart rate. And then the green line is systolic blood pressure. The red line is MAP, and the yellow line is diastolic pressure. So on this instance, the vertical blue line is right when we had ROSC. And then you can see within 30 seconds of the ROSC, that first blood pressure is coming back, and it's 80 on like 50. And so they're immediately administering push dose epi. And then what you can see is that there's these big waves, kind of big increases and decreases in blood pressure, and that's called the epi wave. And so you have somebody giving a push pressor epinephrine, and so you get increases in blood pressure and decreases. And then what's very interesting is when they started the norepi infusion, and it's kind of annotated there. I don't know if you can hover over that, Adam. Yeah, right here is the norepi infusion. And as the patient becomes normotensive with higher and higher doses of norepinephrine, the pulse rate actually comes down, and this patient is much more hemodynamically stable. And just a little background here, I think I forgot, is that this was a cardiac arrest due secondary to an opioid overdose. But you can see that this patient was 100% was going to rearrest, but they implemented their push dose epi, concurrent fluid, and started a norepi infusion to keep this patient hemodynamically stable.
So what we found then is that we've started to deliver these life-sustaining therapies in the field. And we saw that by our arrival to ED going from up to about 88%. And so when we started going to the hospital, we had these 4 cases. And now, unfortunately, with these 4 cases, what these are cardiac arrest or rearrests that all happened at critical handover of care. And so the significant problem with that is when we do that, we are literally breaking the chain of survival, right? And so we can't really control as great as we are with our telephone CPR, our bystander CPR, and our AED programs. We can only influence that very minimally. If we don't have a dispatch system that does telephone CPR, if we don't have bystander buy-in to do CPR and to use public access AED, There's not much we can do in terms of EMS and healthcare providers or hospital staff to improve those numbers, but the one link that we can actually make sure we maintain is the link between EMS and hospital staff. And so we'll go over a couple of case reviews here and show you those 4 cases that I showed you. These are 2 of those 4 cases. And so this is case study number 1. And you can see again that vital trends report, that horizontal blue line. And so you can see that our members are giving epinephrine a log here. This is all push dose epi, or sorry, this is cardiac epi. They get their ROSC back. And you can see our blood pressures are quite low. Now, we do have a protocol that states you have to get your blood pressure within that first 30 seconds. But I can tell you the reason you're only seeing 5 on here is because these 5 blood pressures were the only ones that came back with the NIBP. When we look at the data, we can see that there was multiple attempts where they would get NIBP timeouts. And one of the things that we've recognized and that we have directed our membership is that if you are getting a blood pressure that takes an extraordinarily long time to come back, or you get NIBP timeouts, those are because those are severely hypotensive patients that the machine is not picking up on. Okay, NIBPs are really good for stable patients, but they're really terrible for unstable patients. And so there is lots of auscultated blood pressures in here and lots of timeouts. And you can see getting close to about 1308 is kind of when that last blood pressure came back from the machine. They were able to maintain some treatment along there, but you see where the clinical handover happened. And all of a sudden, there's this rapid drop in pulse rates. So what happened here is our crews are getting close to the hospital, and they changed their mindset. And we've all done this at EMS where we know we have a critical patient. They need to be out of our ambulance as quick as we possibly can. And so what we're doing is we're turning it over and we're getting them out of our back of our ambulance into the hospital where the definitive care is, where there's a better treatment plan. The problem is we change our mindset from sustaining life to transferring over. And so we've already talked about, we get that rapid drop in blood pressure, we get the rapid drop in pulse, and then a rearrest happens. Okay.
Adam, I think on that point there is that our members actually forgot the push dose epi in the car, in the truck. Right. And so this patient went a few minutes without getting a vasopressor.
Right. And so we look at case study number 2. And so for those of you who are unfamiliar, this is what the information or the data you get back with AccuVent, which is a real-time BVM feedback device that is incorporated into our ZOLL X Series Advanced. And so that top line that you see there that's a ventilation volume. So that's your rate or your volume per milliliter per breath. The ventilation rate is that middle section, and the blue lines are kind of where you set your machine up. So ideally, you want that 10 to 12 breaths a minute, and that's where we set our machine. And then that bottom line is end-tidal CO2. I believe everybody on the line is familiar with end-tidal CO2 and how that works and how that looks. And so I'm not going to tell you when clinical transfer of care happened, but what I will point out is that we're doing these great care at about 12 breaths or 10 breaths per minute, roughly 450 to 500 mils per breath. And then all of a sudden, there's this rapid increase in ventilatory volume, sometimes close to 40 breaths per minute. And we go from 400 mils of air per breath to almost 900, 950 in some points. And so, as you can probably guess by this slide, getting close to 2010. Right? So this is the patient that comes in. What's happening with this patient is they have this sustained ROSC, which you can see from the purple line up top there. And that blue horizontal box that's showing right here, this is the time frame in which we're looking at, okay? And so what you see is the pacer going, the end-tidal C or the norepinephrine infusion is happening. And here's where we're transferring care over to the hospital. And what happens here is the hospital just shut down our machines. They turned off our pacer. They disconnected our norepinephrine because what they were concerned about was getting them off of the EMS stretcher and onto the hospital bed. They want them on their equipment because that's what they're used to and that's what they're comfortable using. And we don't blame the hospital staff for that at all. I think if the roles were reversed, we do the exact same thing. If you are comfortable using a piece of equipment, you always want your equipment to be there. And so what we can see here is if you look at 2014, 51, that's when the pacer shut off. That's when the epinephrine is stopped, or the norepi is stopped, sorry. And then we talked about what yellow means again, right? So if we look at 2016-09, so less than 2 minutes later, that CPR started again. So again, the pacer is stopped, norepi is stopped at 2014-47, and then, or 2014-50, and then again at 2016-09, we're starting to do CPR again. And so we took those slides, that information, and went to our hospital and came up with a clinical handover. And Mike, what's the line you say? It's no one's fault.
Yeah, it's nobody's fault, but it's everybody's responsibility. And a quick story here is that we presented those slides, exactly what you guys just saw, to our medical director and our clinical educator and our lead of our ER. And after presenting that, and we're just saying, hey, there's a chance here to improve some quality of and certainly some patient safety. How do you want to do this? And so I got invited over to the hospital to kind of game plan of what a simulation might look like or what some training might look like. And while I was there with a clinical educator, Randy, she's like, "Hey, Mike, we just got a patch. There's an agency bringing in a post-ROSC patient. What do you want to do?" And I was like, "Why don't we just watch and see how it goes?" So it was super interesting. The EMS rolled into the trauma bay. They took all the stuff off, all the equipment. They moved the person over. They were actually using push dose epinephrine. And then they started hooking all the equipment back up. And I look over and I look at Randy, and she's kind of tapping her foot here and goes over to one of her nurses, like, "Hey, let's take a blood pressure." And then the blood pressure comes back at 70/40, and now there's a big panic to get the norepi going, and there was a really close call that almost ended in a cardiac arrest. And she looks at me, she's like, I have never looked at it like this. And so really, this was what we came up with of how we transfer a ROSC patient.
And we should add that when they rolled into the trauma bay, they were sitting about roughly 130 systolic, right?
Yeah, it was a normal intensive reading, and then all of a sudden, mysteriously, 4 minutes later, we're almost having a cardiac arrest. And so this is what we came up with. It starts really with that pre-arrival. And one thing that a couple things that I'll highlight here is that when we give that pre-arrival report, our members have to include if the patient was given any vasopressor. What you see there on the ER team, what their assignments and roles are, is one thing I'll highlight is, hey, get the norepi out of the fridge and get it ready to go. And so this is just their cascade of events that they're going to do when they know we're bringing in a ROSC patient. The next thing is the ER team's just going to confirm what dose of norepinephrine we're going to use. They use a different concentration than we do. And then here's kind of the meat and potatoes, is that we're going to leave that patient in care of EMS while we give that handover. And that really ensures that there's no gap in treatment. And so our member will be giving verbal handover. The ER team is able to listen to that verbal handover, not be task-oriented, and fully understand what the presenting pathology is. And really what we found is that you can't do both of those at the same time. You can't understand what's happening and be doing a task at the same time. And so the ER team's going to continue the treatment on our monitor as they understand the story. And then once the story is given, we're going to take one last blood pressure. We're going to adjust our vasopressor if we need to. If the patient's in a deadly cardiac rhythm, we're going to administer electrical therapy. And then we're going to brief the RT team on what the ventilatory strategy is. And so after that, we can now safely transition that patient to the bed, and any final questions can be asked and answered. And really, all we're doing here in this is that we're just injecting a few more minutes of time so that everybody can understand what's happening, and then no gap in treatment happens.
Yeah, and so, this is the way that we were able to actually close that chain, right, or keep that chain intact. And so one of the nice things is we were invited to give that talk, give those slides, develop that program with the hospital staff. And so we ended up going to the ER clinical educators, their education week, and we gave them those exact roles and functions, the interaction between Lethbridge or LFES and the hospital staff. And so it's great if all we're going to do is go and talk to somebody, but this is what it actually looks like in real life. So again, if all we do is talk about it, we don't evaluate the actual process, how do we know it's being successful? And so this is a ROSC patient that we have here, and you can see arrival at the hospital is right here. And what I want to point out is that all these V's that you see, those are NIBPs. And so our crew, from the time they arrived just before 1403, and they transferred care at about 1509 there, maybe 1510, is that there's 6 blood pressures happening in that time frame. So we're doing Q 1-minute blood pressures. The push dose epi if needed was continued. The norepinephrine was continued. And you can see a really successful handover. And so one of the nice things we know about this is if you look at those bottom lines, so we've got respiratory rate and end-tidal CO2, is we left them on our monitor with end-tidal CO2, our AccuVent system, using that while they were stabilizing and making sure that everything else was caught up. So we were able to continue with that patient treatment. Here's another one. Another example here is they arrive at Chinook Regional Hospital, different crew, different day, in the middle of the night here at just before 20 after 12. And so at any point in time where you think that there could be a potential for delay due to fatigue or anything along those lines, and it's not. The scripted rules work. And here's 5 blood pressures that were taken. And then, so this is the next I'm going to show you is, this is a new one we've got. So this one is not, we've noticed that this process is starting to leak over into not just ROSC patients. And so what you're looking at here is a 77-year-old male who was septic and severely hypotensive. And so our crews, Mike has got a great phrase. He calls it HAPPY, and it's hypotensive, aggressively addressed with pharmacology. And so this is what we call one of our HAPPY cases. And so our crews recognize that if this was a ROSC patient, they know the treatment line that's ready to go instantly. And so they started to do that in the house with a septic patient. And so they're giving norepi in the house. They early patch to the hospital. As they start to stabilize, and you can see the blood pressure rising up, the patient starts to interact more and starts to stabilize and is now able to communicate. Initially, when our crews walked in, they were obtundant. They had no recollection that there was even anyone else in the room with them. And so when our crews were able to then repeat the patch back to the hospital, we'll give them the update. And when they walked in, the entire group is sitting there waiting for them with the norepi out. And the exact same process for a ROSC patient happened for this patient, where they did not rush. They took multiple blood pressures, which you can see there again, 5 or 6 BPs over that 5 to 6 minute transition from ambulance bay to emergency room. And so, Mike, you go ahead and talk about this one because you know this one.
Yeah. So this is a little bit of a proof of concept of what we're talking about. And so this was a 60-year-old lady who had a witnessed cardiac arrest with a shockable rhythm. And what I'll just point to, that first blood pressure is 70 on whatever. And so they start doing push dose epi, they start a norepi infusion, and they actually titrate the norepi up to 0.3 mics per kg per minute. And you see a blood pressure of just under 140 systolic. This crew and the ER team started rushing through the process, and there was a miscommunication. The communication error was, we want to transition the patient over to the hospital concentration of norepinephrine, and a nurse just turned it off and thought that the other concentration was at bedside and ready to go, and it wasn't. And so what you see here is a rapid deterioration of blood pressure, and it actually got down to 50 on whatever. And so this patient is so close to a cardiac arrest, and it was caught by a nurse and a paramedic. They're like, oh, geez. And then they quickly turned back on the EMS norepinephrine. And we believe that this would have been a cardiac arrest prior to implementing this program. And instead, it was just a close call. And so every time we have one of these calls, we forward it on to the hospital for quality improvement. And Roseanne here, she's a retired bus driver, and she's sharp as a tack, and she's a lovely lady. And she was able to come by and hang her survivor plaque up on our wall. And we just believe that there's a good chance, if we didn't go through this process, that she wouldn't be there. And so here's a proof of concept and a person at the end of this.
And so before we go to the next slide, Peter, we'll give you a second to get a pen and a piece of paper because we know we've talked about our R&D department before, and everybody on the line has probably heard this, but we can't remember where we've picked this up. But one of the things that we've noticed is if you treat pediatrics like adults, we can have this same effect. And so again, I don't know where we picked that up, but by all means, anyone feel free to use that as much as you want. Go ahead, Mike.
Some crazy guy. So we're
gonna highlight a case of where we really learn from and kind of highlights how a smooth ER transition really starts with EMS stabilization. And so this is a case study a few years ago of a 1-year-old that had a cardiac arrest. The patient presented in a PEA, and our members performed approximately 10 minutes of CPR. They placed an endotracheal tube, an IO. They gave 1 dose of cardiac epi, and they achieved a ROSC. And so here's the initial rhythm on the ROSC. So you have a yellow section, a purple section. We got a ROSC. And I would like to just add and emphasize that this patient's ventilatory status was optimized with an endotracheal tube and 100% oxygen. So what do? Well, we packaged the patient up. We didn't do a complete assessment. We didn't do a complete set of vital signs. We ran out to the ambulance, and then you can see where CPR started with symptomatic bradycardia, and that's about 5 minutes later. And so this patient experienced symptomatic bradycardia despite their ventilatory status being optimized. And a lot of times in our PALS courses, we always talk about symptomatic bradycardia. It's usually caused by a respiratory, but we never talk about when it's not caused by respiratory. So this patient was post-ROSC, and post-ROSC patients are at high risk for metabolic acidosis and/or cardiac stunning. And so this patient had a rearrest with symptomatic bradycardia, so they started CPR again. They gave another dose of cardiac epi. Next slide.
Well, if this was a 65-year-old, right, we would know what to do.
100%. And if this is a 65-year-old, we would have had a mile of blood pressures, Q1 minute. If that patient was in a hyperperfusing state, we would immediately intervene with push pressor epi and started a norepi infusion. And so where you can see ROSC next, and this blue line is when we showed up to the hospital, and we're now doing CPR. We show up to the hospital. Next slide there, Adam. And this is where the ER team and the ER physician, they started push pressor epi and started an epinephrine infusion. And really hemodynamically, the patient was stable after this. And so if you look at that arrow there, 1405, well, we could have had that exact treatment probably 10 to 15 minutes earlier. And so this patient needlessly had a hypotensive episode, and that really represents a secondary anoxic brain injury. And so we have embedded this course into every one of our Handtevy courses. You can't get through an LFD Handtevy course without actually going through this case study. And then anytime we do scenarios, post-ROSC scenarios, they're always hypotensive, and you have to intervene with either push pressor or an epinephrine infusion.
Yeah. So let's contrast that story with this one. So this is a 13-year-old cardiac arrest, and here you can see
this was our last ROSC patient, or pediatric ROSC patient. Sorry.
And so this was a basketball player who ended up going into cardiac arrest while at the school playing basketball. And bystander CPR was done. The team or the school had an AED, and so they were able to run down, get the AED, call 911, bystander CPR, performed a shock on that patient, and our crews come in and provided an excellent level of care. And you can see here that they were able to get a ROSC back. They continued to treat that patient exactly like they would if they were an adult. And they arrived at the hospital, and again, you can see multiple BPs over through that transition of care. And we ended up having a positive response from this one. And so this is Cameron. Cameron's in the middle with his family, and he was able to come and hang his plaque on the wall. And one of the other things that we were able to do with this story or with this situation is we now go into Cameron's High School and we were invited in to teach hands-only CPR, or sorry, to teach cardiac crash, which is a heart and stroke program. It's hands-only CPR, AED use, and Mike has been critical in implementation of their cardiac response or their cardiac arrest response group within that school. That school is going to take that to their superintendent, and it's going to go out now to the rest of the school division in our area. And so one of the things that happened during this was, and Mike told me this story just the other day, was the coach asked, how did your guys know what to do? So when they walked in the door, nobody talked. They just simply went to work, and the anxiety level in the gym, the anxiety level from everybody just mellowed out because the crew was so professional and so great at doing what they did that it took all the stress off the bystanders. And so Mike showed him our performance, our roles and functions, our high performance system, explained to him what it was, and he said, wow, that was amazing, because that is exactly what he witnessed happen with those folks. Go ahead, Mike.
Yeah, this is and just kind of more to the point of that Adam made before, is that our transfer care is getting better because we've gone through this process with our ROSC patients. And so this is actually a 2-year-old who was attacked by a large dog and had deadly bleeds from large lacerations from the neck and the base of the skull. And so what you see here is what you'll notice is absent here is blood pressures, because they couldn't get one. They couldn't auscultate a blood pressure. They couldn't get an NIBP. This patient presented with saturated in blood in mom's arms, with a weak central pulse, and then was also having periods of apnea. And so our paramedics, they applied direct pressure, suction of bloody airway, OPA, BVM. They drilled the patient, and then while all this was going on, they're chatting with the hospital on the patch line. And so what's really interesting about this call is that from the arrival to the ED line until blood starts is about 5 minutes. We have built, and I would say that's probably fairly unusual within the industry, to get blood on board within 5 minutes, and that's because the increased communication, the increased trust. They actually started their massive transfusion protocol prior to us arriving at the ED, and because there was such a good communication leading up to it, and we built a really good relationship, this patient was minutes away from a cardiac arrest, and because they got infusion of blood products very, very quickly, and then became normotensive within a few minutes after that, it was a positive outcome. And so here's one of our medics meeting the patient afterwards, and just a great story. And these are the type of stories that you're going to get when you invest in that relationship at the hospital.
And so, this is great, but this always takes money, right? It takes money, it takes time, and it takes effort. And so one of the things that, and Peter, you'll have to help me out, Dr. Victoria Myers and Dr. Garrett Monk a few weeks ago talked about having these defined roles in the hospital. And one of the questions and one of the things that was brought up during that presentation was, how did you get your hospital administrators to buy in to fund these programs, fund access to the software that you need, fund access to the time it is that we need to do it? And my response to that is, well, what is the cost of a rearrest? And so we can look at several different things. The very first thing that's going to happen when you're in a center that has a rearrest or a cardiac arrest come in is you're going to delay treatment for other patients. That's not because we choose to delay those treatments, because those cardiac arrests take a lot of personnel power. And so those personnel are going to be drawn away from their regular duties, the patients that they're looking after. Everyone who's covering for them is now going to have double the workload because they're going to cover. The other thing you're going to do is you're going to miss breaks, you're going to miss meal times. So now all of a sudden, you're going to have to make these up. So you're going to make these up in one of two ways. You're just going to push them all back together, combine them, which makes those breaks longer, or you're going to pay overtime for them. Right? We're going to have increased mental health anxiety. And these things are big. The cost of a rearrest on your staff members, the morale of the day, and if it's only one, it's bad. If it's 2 or 3, it just amplifies and gets worse and worse. That increased mental health anxiety, that's going to increase to larger amounts of PTSD. That's going to start to go to workers' compensation board claims, insurance claims. You're going to increase your staff burnout. And oh yeah, well, all of these things are happening every single time. The one thing we still haven't accounted for is the other 50 to 100 patients that have now come into the emergency room who's expecting that pre-arrest level of treatment. So they don't care that there was a cardiac arrest. What they want is they want to be able to be treated the exact same way in the same time frame. And so does this actually work? And what I can tell you is yes, it does. So since program implementation, we have had 40 clinical handovers of ROSC patients, and there hasn't been a rearrest. So I'll put it to you another way. We have now gone 428 consecutive days without a clinical handover arrest. That doesn't mean that these other things with the missed meal breaks and the increased workload and the increased mental health stuff hasn't been happening for hospital staff. But what I can tell you is that we know that these rearrest cardiac arrest cares or these rearrest clinical handover cases aren't contributing to that problem. And so one of the things that we are all very, very, very familiar with the care continuum or the continuum of care. And so the problem is we tend to look at it this way, where we have community, we have EMS, emerge, inpatient, discharge, back to community again. And the problem with this is when we look at this in a linear theme, we get siloed. So the community care stuff has its own role. EMS has its own role. Emerge departments have their role, and they're not actually linked or interactive. But the truth is, we need to start looking at this as a circle, right? What happens in the community care, community personnel, the problems going on in your community, that's going to affect our emergency medical services, our EMS services. What we do in the field is going to affect the emerge department. If we miss a critical patient, that's going to backlog that emerge department. If that emerge department doesn't recognize a critical patient, that's going to increase the amount of time they're in an inpatient. It's going to potentially increase the amount of care they need moving towards the discharge coordinator, which goes back to the community, which again, if we are not optimizing our care, optimizing our treatment plans, then all of that goes back to the community, which then increases once again the amount of interaction they need with EMS, which we are then going to bring that patient back to the emergency department again. And so these things, we really need to start thinking of them as opposed to siloed events, that they are all interactive and everything we do on scene can affect it further down the road. Every handover we do in the emergency department affects that patient as they go to discharge again. And with that, that's all I have for you. So thank you very much. I appreciate the effort or the listening that you've provided us and the avenue we've been able to present to this. We do have our contact information up on the screen, which I'll leave on for another moment or two. And then, sorry, Mike, there was one thing you wanted to add, I think, at the end.
Yeah, the only thing I would add is that this doesn't just happen on its own, right? You know, if you want to build a relationship, it's not a one-time thing. We track every single time we do a post-ROSC handoff. We give that feedback and try to get feedback from the ER team. And so we've had close calls, we've had hiccups, but really what we've created is a term of reference so that we can have that conversation of, hey, what went wrong or what went well? How do we get better or how do we keep doing what we're doing? And so that's what I'd like to end with.
I mean, I'm blown away of so many questions, and I think that, and I hope that other folks, you know, either raise your hand or there's a lot of questions I'm going to go through right now in the chat, but most people are probably looking at this. And so I just have some overarching questions and I'll drill down. How many patients are you seeing every year in Lethbridge? Like, what's your total call volume transported? And then how many arrests do you see every year? Can you start with that, just so we get a glimpse of the numbers?
It's a little bit variable because we actually had the unfortunate distinction of having the highest opioid death rate of any city over 100,000. And so we had 2023 was a crazy year for us. We had I think it was 130 arrests. A city of our size should be doing about 50 to 60. And so we had a really big increase in 2023 there. But yeah, about 50 to 60 a year is what we're supposed to be doing.
And the population what was it again?
120,000.
Okay.
Yeah, so we have a population in town of about 104,000, and then our greater response area brings us up to about 125. And so from
Okay.
January 1st, 2022 until the end of December 31st, we did 218 adult cardiac arrest plus some pediatric ones. And so last year in 2024, that number has come down back to our normal site. We're looking at about 77 cardiac arrests within 2024. We just haven't been able to add that data into our presentation yet.
Okay, so what I want everyone to do is just do a little bit of math for your own community, because their math lines up to all of our maths, which is the following. And I'm doing this for a reason, just bear with me. So they have 120,000 population. So everyone just take that number, whatever your population is, and just remove the 3 zeros. So we're going to go with Lethbridge as 120. So 120,000 population, 120 arrests. And typically you will only work half of those arrests. So right on point, half of 120 is 60, which is exactly kind of where you guys are, right? So Davey, in Davey, we're about the same number population, and therefore we work the same number of arrests. And why am I mentioning that? Is because you have an opportunity for 60 people to actually have some life-saving event. So Adam and Mike, how many patients last year did you get? And again, if you don't know this offhand, but I'm just trying to make a distinction between the number of patients last year or before this process started that rearrested and never came back to life versus the number of patients that you were able to save. So what is that difference between beforehand, 60 a year, to after the process started? How many additional patients were you able to save just by starting this process? That's really the question I'm trying to get to here.
It's tough to tell, but like from that one picture of just clinical handover arrest, clinical handover, we certainly have at least one, right? And so it's really hard to say, hey, this person would have lived or this person wouldn't have implementing this. But we do know that our arrival to ED is much higher since implementing our post-ROSC bundle of care.
Right, and I was actually including that bundle of care too, because so you had, before you started that process, you had a bunch of rearrests. It went from
There's about 50% rearrest rate to a 23% rearrest rate.
Right, and of those patients that did not rearrest, how many of them walked out of the hospital? Because a few people are saying, oh, the ROSC is great, and we saw a couple of photos of the people who were alive.
Yeah.
But how many more people walked out of the hospital neurologically normal because of those two processes that you implemented?
Yeah, Peter, I don't think we have good data on that yet. We are entering our data into CanROC, which is the Canadian equivalent to CARES. It just takes a long time to get some of this stuff.
Yeah, I will add that we do submit that through, and that information, unfortunately, is just not back to us yet. And so we are waiting for that. But what I'll say is that I know neurologically intact survivability, walk out of the hospital, is the absolute gold standard. That's what we're aiming for. But I think for EMS, that's a lofty goal with very little ability to impact that. And so what Mike and I concentrate on is getting pulse to hospital. Because once we transfer that care to the hospital, we have absolutely no influence over what happens in the emergency room for care-wise, what family conversations that happen about withholding treatment, and about what happens in the ICU moving forward. So I think when we start looking at EMS services, that's a lot harder to link your programs to neurologically intact survivability. Really puts us in an environment that we have no ability to control or to influence at all. And the other thing that we'll say is, for a while, Lethbridge, a city of 104,000 people, a response on about 125,000, was the largest contributor to the organ donation program in Alberta. And so what does this mean is that, sure, we brought patients in that were in cardiac arrest, we get ROSC back. They're not a neurologically intact survivor. But they were able to generously donate their organs, either pre-choosing it and having it linked into their Alberta healthcare number or their driver's license, or their family made that choice for them. And so they were able to then harvest some organs and have those other citizens in Alberta and Canada be able to then go on and live a more normal life. So what's the value if we're linking only to neurologically intact survivors? I think we're missing the ability to have a huge value attachment to organ donation, to having people come off organ donation lists, and the quality of life that those individuals are then able to provide or to have post cardiac arrest of somebody else.
Yeah. I think there's also a little bit of fallout here where our medics are intervening in those peri-arrest patients at a much higher rate. So those patients that have no blood pressure, they have acute coronary syndromes, severe respiratory distress, or altered LOC, and they're intervening very, very quickly to prevent the arrest in the first place. So once again, that's actually really hard to figure out.
Yes.
Because they don't actually go into cardiac arrest.
Right. And so the overall kind of issue here, just so everyone understands, is that if you're only running 60 arrests a year, which is, most cities are going to kind of be that size or maybe a lot less, and only 20% typically are VF, right? So 20% of 60 are 12, right? And if you're the best agency in the world, you're at 60% of your Utstein, which is a witnessed shockable rhythm. 60% of 12 is like, let's say 7 people, right? And that's the very high performing. So if you're not a high performing, then you're only going to get back 1 or 2 of those people, right? So what you guys are doing, and I don't think people really recognize the gravity of it, because what you're doing may bring back 2 or 3 patients additional than what you're getting already, maybe 4, maybe 5 if we're lucky, right? So going into one location, Lethbridge, and saying this process changed the world, it's going to be hard to do, right? And that's why we have CanRock, and that's why we have CARES, so that we can aggregate everyone's data. But what I wanted to do is show everyone this slide, okay? And the reason I want to show everyone this slide, and I showed this recently in another presentation that I gave, which is that this is from CARES. This is the Cardiac Arrest Registry for the United States. And basically, they are showing us the states, and they're comparing states by overall survival percentage. And you can see that the state of Washington is above 14%, and the state of Vermont is like close to 7%. So you have one state is double the amount of survival. And when I look at that as someone who manages small agencies and very large agencies, I know that the differences here that you see are all going to be found in the patients that are on scene. Are we treating them correctly on scene, push pressure epi, doing vital signs correctly, etc., and in the handoff. You had just mentioned that what happens in the hospital is a whole nother ball of wax. It turns out in CARES, the hospitals are also given a percentage of their outcome. So I, as a medical director in Broward County, I can go and see what hospital A, B, C, and D, what their outcomes are. And I can very quickly see which hospitals are performing well and which are not. And in the state of Florida this year, we now have something called Resuscitation Centers of Excellence, where the hospital has to attest to, I'm going to do all these things correctly. And we actually created a document. And if they don't do those things, we don't bring them patients. And lo and behold, these hospitals are very, very, they're trying to hold back to signing the document because they know that it's going to cost them time and cost them money to do that. But for all the people who are on this call today, if you're in this graphic, not only should you know what your state is doing, but you ought to know what your agency is doing so that you can start to do better for your patient. So Mike and Adam, I would love for you to comment on, let's say, how Lethbridge is doing compared to another Canadian organization or something else familiar. Are you seeing your numbers at least higher than the others? Because at some point, you guys are going to have to come to the table with the numbers to say, here's our neurointact survival data, or here's our overall survival, like I'm showing you here. Here's our data, in order to show a year's worth of data, 2 years worth of data, in order for the people outside of your community to say, we believe in what you're doing. Thoughts on it?
So one of the things that we're able to recognize and what we're able to do is so just to give a bit of background for how our organization works, right? We are a contracted EMS provider to Alberta Health Services. Alberta Health Services is a provincial or a state-run organization. And so healthcare is run under one body, or it was for years. It's being changed now. But every EMS practitioner in Alberta works under the same protocols, works under the same system. And so one of the things that we were able to do is we're about 2.5 years ahead of everyone else. And because we are a nimble service, we're a high performing service, and we're able to get this out quickly. The rest of the province has now mimicked what we're doing. And so when we look at the direct delivery service, so we've got roughly 200 paramedics on staff, just a little bit more than 200 paramedics on staff, where they've got a few thousand. And so now they're going to transfer out, and they're taking all of our programs, all of our data, and they've started to look at their data, and percentage wise, it mimics where we were 2 years ago. And so they've been able to walk through and start showing, hey, here's where we were 2 years ago. Here's where Lethbridge was. Here's where they are today. And it's almost 2.5 years behind us. And so they are going to catch up. They will get there eventually. I think it takes longer. And I don't know if Ian Blanchard happens to be on the line. So he's our primary investigator, our PI up here in Canada for us. And he'd be able to speak better to that. Or if Ryan Lee is also, if he would happen to be online, he'd be able to talk to it as well. But that is so we're now able to compare our service to the rest of the province. And what we're finding is that everything we're doing, they are able to get to us, or other services are able to mimic what we're doing. And so those numbers are already improving across the province. And so we're actually, and Mike, maybe we'll touch on this a little bit.
Yeah, I guess one thing here is Peter, you're asking us for the smoking gun, and we don't have it, right?
No, listen, honestly,
we're working on it. We're
Yeah.
working on it, and I totally get. Hey, that's where our goal is to get to that smoking gun evidence, and it just takes a lot of time. But having said that, in the meantime, I think what we're doing here is the clinically right thing to do. And when you do the right thing, you get good outcomes. And so I'm not worried about the numbers. I'm more worried about the people that we care for and that our medics are doing the right thing.
Listen, I'm in the same exact boat, and I'm embarrassed to say that I end up just posting my data on LinkedIn, right? I post it out there. And what I realize is that I get about at least 5 emails a week, and people say, how do you get those numbers, right? And they're waiting for like a single line answer.
Yeah.
And when I start to ask them about your high performance CPR, how are you training? Do you have a CQI methodology? Do you have code stat, or do you have case review? Either LifePack or Zoll. And I'm asking some very basic building block questions, and people are waiting for me to say, oh, do you have some like magical medication?
Yeah.
No, it has nothing to do with that, right?
There is a magical thing, and that's personnel, right? You need to have the right personnel who want to improve, who are driving the change, who are looking to be these champions of change. We are not just finished some interviews, and we're doing a recruitment drive, and one of the common themes that we heard in every single applicant that came to us was, I know what you're doing with cardiac arrest, and I want to be part of it. I know where you are, and you are the leader in emergency services, and I want to be part of this team going forward. And we're not done, right? We're gonna, and Peter, we'll see each other at FAST 2025.
Yes.
In Calgary, and you're going to hear Mike talk about ROSC 2.0 there. And so we'll spill it a little bit. Mike has developed and realized that what we're doing here is great, but we think that we need to be even more aggressive. And so
I can't wait to hear that. Yes. And I see Ryan Lee is here. So Ryan, if you're here, we'd love for you to unmute. And then Dan Moran, I'm going to come to you because you were the guy who put Davie, Florida on the map. We stole you away, kind of thing. But Ryan, can you unmute yourself and talk about your comment?
Sure. So, we have I'd say a really good collaboration within the province of Alberta under cardiac arrest. I think it started with Ian Blanchard, the primary investigator, traveling down to Seattle to the Resuscitation Academy. It started with creating a provincial cardiac arrest registry. It's all about who you know. So I known Adam for quite some time back in the city of Calgary EMS days. And Adam was the one who approached Ian and myself about the cardiac arrest that we were just starting to look at way back in 2017 before COVID. And the knowledge that we had gathered, we spent time trying to teach it to Lethbridge, and they're such an amazing service. They took that knowledge, they were able to translate the information into the protocol that you see for push-dose epi. They're working on a post-ROSC. They got 2.0 protocol to really streamline and optimize the post-ROSC care. Because I think one of the things is, it's exactly what Adam said. It's not a linear process anymore. It's a continuum. And how we evolve that continuum of cardiac arrest care only benefits not only the agencies, but the community for our patients. And then we continually strive to be better. And then what we're trying to do is catch up. And so, I mean, we are a ship of almost 5,000 to 6,000 paramedics within AHS. So we don't move very quickly. It takes forever to change our ship. But Mike and Adam are able to take the knowledge that we get, and now it's no longer academic knowledge, because that's where it started for, was in the academic sphere with research literatures. But now we have created our own provincial data set where now we can look at Lethbridge data. We can look at the direct kind of the direct delivery model, so AHS data, and have those different comparisons through all the different agencies. The only thing is, your question is about 1 year too soon, Peter.
Right.
Because in a year from now,
I'm marking it on the calendar.
yeah, we should be able to give a lot more of that data. But then I think Adam mentioned it. It's time and people. We are a very small research team in Alberta, and we sit provincially, including Lethbridge's cardiac arrest information. We do about 7,000 cardiac arrests in the entire province of Alberta. So you were talking before, say 4.5 million population with about 7,000 cardiac arrests. And our group, and that includes everybody, all the contract groups and everything, that's the data that we look at. And so that is where we're trying to catch up on the data. So when you think about talking about Uthine variables, talking about ROSC rates, talking about survival to hospital discharge, we're still behind because we're still trying to process all of this data to present day. And that includes the Lethbridge data, because they'll collect it, but they don't get, because they're a contract agency, they actually can't go to the provincial health agency to get patient outcomes. They actually have to go through our group. So it adds another layer to their data collection. And then again, big organization, slow to get the patient outcomes. And that's what we're just working on now with, they have a 4-year data set where we can look at actually the pre and post of their push dose epi. But even now, with knowing the start date of when they implemented the clinical handover care protocol, we can even look from that point forward as well of what they're doing. So again, a year from now, Peter, you'd have all your data.
Oh, wow. I'm following you guys like no other, and I'm looking forward to it. But hopefully what people are hearing on this call today is there's a couple big things, and Dan, I'm coming to you in a minute, that everyone needs an Adam and a Mike. And, you know, I'm fortunate to have Dan in one agency. I have many folks in other agencies that are, you know, one or two individuals who change the world, number one. You know, you have to go beyond the high performance CPR. So I think there's, you know, if you're looking at the building blocks, there's the how to do the CPR on scene. Okay, I think that should be table stakes. But now you're moving on to post-ROSC care. That's another big building block. And now you're moving into ED handoff. That's another big building block. These are all things that will impact your outcomes that we're all looking to increase, right? And really glad you guys are doing the data collection and you guys are progressing as you are, and we are following for sure. So Dan, let me come to you. So you came into an agency, obviously you were there for many years, you know, even before I became the medical director. But talk to what Mike and Adam have done here and then what you've experienced, because I want people on this call to understand that it's not, there's nothing magical about all this, really, right?
Yeah. Absolutely. And thank you for that credit that I definitely don't deserve, but I appreciate. I love listening to Mike and Adam. I'll tell you, every time they talk, all the webinars they do, you learn so much from them. And one of the biggest, the first take home point that I got from the entire webinar today was they used data. They used real patient data in their code stat or the rescue net or whatever that product is, right? So that's take home point for everybody in EMS and in the ERs. You need to be looking at your cardiac monitor data. Don't look at opinions. Don't look at how the crew, says they're performing. Use real data. And now when you look at that, they found trends. They took that data to their medical director and said, we have to address our protocol and adjust these to make it a real-time change. So when patients are deteriorating in the field or they're rearresting, we're trying to prevent this from happening. So I love that. That is such a huge point. Protocols get addressed, and now what are they doing? They're monitoring to see how effective it is. I love this. This was a great webinar, guys. Thank you again for being on. So for everybody else listening, whether you're in the ERs or EMS, I would say looking at that cardiac monitor file is important and sending that feedback to your providers. You heard Mike and Adam, within 24 hours, they're sending that feedback to their providers. I can't tell you how many ERs I've been in, and we ask them about this. And one, they typically don't know that that data is even available to them. And two, it's definitely never given to them. In EMS, it's more work. I was a chief for, 8 years before I retired, and I can tell you it's more work. But you know what? The work is so worth it. I always said we owe it to the patients that were in cardiac arrest to their lives to say, did we do everything possible to save this patient? And typically the answer is yes. The crews did an outstanding job. They performed very well. Our last year's CARES data was 75% for Utstein bystander. I am so proud of the Davie Fire Rescue crews, but the reality is no matter how amazing they're performing, there's still opportunities. And if we all have that drive to try and improve patient outcomes, we're going to have more survivors. And, I heard that comment in stats about 2 or 3 more survivors for the year. You know what? If that's your family, those 2 or 3 are incredibly important. So a huge kudos to Mike and Adam for their push and their desire to continuously improve patient outcomes. I love it. I admire it. I appreciate your guys' work, and hopefully you'll keep giving us data and outcomes. So Pete, hopefully I answered that the best I could, but again, thank you. And thank you for everybody that's still on.
That was, yeah. And again, if you got to go off, we totally get it. I just love this conversation, and I want to bring other people in. I know there's people on here who want to speak, so you better get at your microphones. But I want to show you what I put up on the screen here. This is what, and Dan started this, back in Davie, but every single medic after every single arrest gets this type of email. And it's very clear here that a lot of thought was put into it, but basically this is just in paragraph format of what Mike and Adam showed you. They go through, in our case, it's the code stat. We go through every second of every compression, every ventilation, every pause, if we get ROSC, if we're pacing, etc. And these are all opportunities. It's not a slap on the wrist, it's an opportunity. So when Mike and Adam are doing within 24 hours, you know what? If you could do it on the same shift, you're tremendous. More than likely, you're going to get it to them by the next shift. So, we do 24/48s. You're going to get it by the next shift. You're going to get an email. We get now emails saying, where's my email, right? And we also get people saying, I want to work at this department because we see what kind of outcomes you guys are having. So I can't stress enough that you got to put the work in order to actually get it right. And then you have to actually, you have to know your data. So what we do is, and I'm sure Mike and Adam, you do the same thing, but, Dan and Chief Gonzalez, we just had a whiteboard, and we had the names of the people that we saved, right? And that's really, because remember, if you're seeing 60 to 70 arrests a year and you get 7 or 8 or 9 people back, that's a tremendous year. That's not a lot of people to follow up on. You should know who those 9 people are who walked out of the hospital. Now, if you're in Ryan's shoes and you're doing 7,000 arrests, that's a spreadsheet somewhere else. But all of us on this call, maybe besides Ryan, should know each and every survivor. And then you just divide the number of survivors who walked out by the total number of arrests that you worked. And that's your neuro intact survival rate. It's very simple. And if you're in double digits, right, then you should give yourself a gold star and you should buy yourself dinner, because that's really good. Royce, I'll put a copy of the protocols in a minute. I want to bring in Lou Steinberg. Lou, I know you have comments. You and I have been chatting on the side. Can you unmute your mic? Former fire chief, CQI guru, and all around great guy. Go ahead, Lou.
Yeah, I just refer, maybe I could put it in the chat, the link to the QAQI webinar, because you don't have to wait for any magic. Just go after your data. Get a relationship with the hospital, keep track of your cardiac arrests, and you'll know pretty quickly who's surviving, who's walking out. You know, the CPC 1 or 2, or as I always put it, can they wipe their own butt when they get done? That's the real simple survival. So we're going to know really if what we're doing is good, because one of the things, and I know you haven't gotten to it yet, is yes, epinephrine, I can give isopril, we can get ROSC, but the question is, not only are they organ donors, but is it doing harm? Are we causing vasoconstriction that can reduce blood flow to organs, maybe even killing potential organ donation, not to mention cardiac, et cetera? So I did ask the question through Peter, do you track primary versus secondary arrests? In other words, those more likely of cardiac etiology or hypoxic nature? Because I would suspect the cardiac, the epi might not be as good and maybe harmful compared to the others.
So basically, are you guys kind of breaking out your Utstein, the shockables, witness shockables versus asystole PEA? Are you looking at those two groups, Adam and Mike?
Of who gets epinephrine?
Well, no,
Or who gets pushed dose epi, or
well, I think Lou's just trying to figure out in general, like of the entire bucket, do you see differences between those two groups, the initial shockables and the non?
And
like I would say,
also.
Hey, yeah, right, but the survival stuff we're gonna wait.
Yeah,
go ahead.
Right.
like so the I guess the short answer is that if the patient is in arrest longer, they need more circulatory support than if they're in a short arrest. So that's what we have found. I don't think that we've really seen a difference in shockable rhythm versus not shockable. It's more to do with how long the patient's been in arrest. I think that is the big correlation. So if you get a ROSC at 19 minutes, that patient's going to more likely need a lot more support than if you get that that ROSC within the first couple minutes of one shock and then move on. I think arrest duration plays a big part there.
Yeah. And I completely agree. What I would tell people is that if you're running a cardiac arrest, you should be getting your vasopressor ready. Period. Yeah. End of story. Every single person, except for these patients that Mike just spoke about, which is they get there, they had some bystander CPR, they got one shock and they're awake, right? Okay, let's take all those patients out. Everybody else is going to be on a vasopressor. Show me one person who didn't end up in the hospital on 1, 2, 3 vasopressors. That's number one. Number two, there's plenty of data now showing that this 90 systolic number is the wrong number, for especially post-ROSC. Now that's actually been published, right? So TBI, same thing. That 90 was the wrong number all along. It's 120, 130. So we need to rethink of what the correct systolic pressure is, or whatever map you're focusing on. But it surely needs to be a lot higher than the numbers that we've been using for many, many years. Adam and Mike, what do you think about that?
That's ROSC 2.0.
That's our ROSC 2.0.
Okay.
So Dr. Handtevy is referring to the Dillon paper. I don't know if you want to send a link there, but we're actually looking at that, and we've drafted up something, and it might be in your inbox.
Okay.
Maybe in a week or two there, Dr. Handtevy.
Okay.
Well, we find part of our Alberta group, one of the members on there is quite witty. And so what's ROSC once you get ROSC also stands for, Mike, on our ROSC 2.0.
Yeah, it's basically, I mean it really is putting people into risk category versus their initial blood pressure, and then your treatment is gonna be dictated on, or your therapy is gonna dictate what the initial, or the therapy that you give is going to be predicted on initial blood pressure.
Okay, well,
but what was your ROSC? What's the ROSC?
Well, I can't give everything away, Adam. I can't give that away.
Okay, yeah. Okay, well, Okay, well, I'm actually going to give away something now. I can't call it ROSC 2.0. I'll call it ROSC 2.1. Ready? Okay, so this is something that we are just now starting to trial in Palm Beach County Fire Rescue, and I have some of my folks on the line here today. So this is basically a beat-to-beat blood pressure from a finger cuff. We have figured out a way, thanks to our EPCR vendor is Metro PCR, and the guy who runs that was like, oh yeah, I can stream these vitals right into your EPCR. So we did that. That was step number one. So now, and the folks in London are using this already, by the way, but this is with a finger cuff, beat-to-beat blood pressure, so that, and I know you guys are taking a lot of blood pressures right beforehand. Imagine having a live, when I say live, it's like an A line, right? This device is so good that it's within 3 millimeters of mercury to an A line, that imagine being in the emergency department before transfer of care, and you're just watching the blood pressure, like that very top bar there, which we aren't using the iPad, by the way, but every about 5 seconds, it flashes a new blood pressure. I think this is going to be a game changer, because right now what you're doing, and you guys can explain this, you're either pressing on the automatic button or someone's taking a manual, right? Is that how you guys are doing it today?
Yeah.
Right. So I think that's going to be something that once we start to have, accurate vital signs, then we can really start to manage patients more accurately and precisely, not just in the field, but then we can get to the emergency department and say, everybody, we're pausing. We're going to do our little pause here, and we're not going to move this patient because their blood pressure is, let's say, 80/40, and before we move them, we're going to give them another dose of push pressor, or we're going to turn up the norepi drip, something like that.
Yeah, and can I
that's in our protocol. Sorry, go ahead, Adam.
Yeah, I was just going to add, Peter, the pause is a great word, and we want to make sure that we reiterate, it's not a pause in treatment. It's a pause in movement. It's a pause in action. So the treatment you're giving does not pause. But what does pause is you take a breath to make sure that everybody understands what the pathology is and what that patient presentation is. And so we have used that term in the past where we said a pause, and people are thinking like they thought we meant you actually pause your treatment to reevaluate. It's like, no, you continue with the treatment. You pause yourself from working and getting task saturated prior to understanding what's going on.
Yes, that's a great one. And I see, Adam, you put the name of the study in there. I appreciate it. There's another big study that just came, I shouldn't say, this is the guidelines were just changed, and everybody has to know about this. So, and maybe we'll get close to the end. I appreciate everyone sticking around, which is, for many years, PALS has called symptomatic bradycardia an arrest rhythm. And you saw that case that Adam and Mike showed you, meaning that you have a kid, their heart rate's 40, and you're pushing on their chest, even though they have a heartbeat, right? But they're altered. So you're pushing on their chest, and PALS and ILCOR and all those other people wanted you to take out 0.01 milligrams per kilogram, so a full cardiac arrest dose, and give it to a beating heart. We, in 2019, saw that Holmberg published a paper where he said, no, don't do that. That's killing people. They didn't adopt those guidelines in 2019. We pulled out cardiac arrest epi for symptomatic bradycardia in 2019. We replaced it with push pressor epi. I almost fell out of my chair last week when I opened up the new ILCOR 2025 guidelines, and guess what? They pulled it out. No more cardiac arrest epi for symptomatic bradycardia for kids. Holy cow. That's brand new. But the AHA has not released their guidelines yet. So PALS officially has not released yet. So regardless of what they release or not, I would just have everyone just read ILCOR. Okay, follow that. That's number one. Secondly, and you have up until May 30th. If you're watching this from anywhere that you follow the European resuscitation guidelines, they, for some reason, are not endorsing double sequential. They're saying it's too logistically complex, even though when you go down a couple of pages, they say you ought to do ECMO. Makes no sense. So You have until the 30th to go in there and put in a public comment. The author of Dose VF, I actually posted his rebuttal on LinkedIn today because it's important for everyone to know that what's happening in the world of cardiac arrest, they don't understand the world of pre-hospital cardiac arrest. It's a completely different animal. Whether there's data to support it, like in Dose VF, and they're not adopting it, or they leave in cardiac arrest epi for kids when they should have removed it many years ago. Folks, it's time for all of us who are in EMS, in the pre-hospital environment, to understand that we need to really start to make assumptions and read the data for ourselves and make modifications so that our patients get the best outcomes. And the only way you're going to do that, going back to Dan and going back to Mike and Adam, is knowing what your outcomes are. You can't go and make a change today if you have no idea how you're doing. If your outcomes are better than everybody else's, I would say keep doing what you're doing, and I'm going to fly to your agency to see how you're doing it. If your outcomes are really bad, then that's that's your spark to say we need to change something. So please follow your data. Depend on your people. I think Adam and Mike said it best, which is, you have to have people who you work with who believe in what you're doing. They believe in the outcomes. They see these great outcomes, and you celebrate the outcomes with them. That's how you transform a department. It doesn't just happen by going and seeing the webinar, right? We are happy to be involved and help. We do a lot of Zooms with people who need help. We will give you all of our stuff. So we call it R&D, rip off and duplicate. If you're sitting here wondering where you're going to start, how you're going to do it, just call us, text us, email us, go to our YouTube channel. I'm going to put my email in the chat right now so that you guys can, you can reach out to me personally. Adam and Mike already gave you their emails. Dan will put his email in the chat as well. But I'm going to give Mike and Adam the final comment. So Adam, we'll start with you, then we'll go to Mike. You have people on here who want to do what Lethbridge is doing. Give them like the next 2 or 3 things to do this year. I'm going to give them some time. You have until the end of the year to do these 2 or 3 things. What do you tell them to do?
So the number one thing you have to do is look at your data. It does not matter what software you're using or what equipment you're using. Zoll, Physio, what's it? I'm picking up Philips. It doesn't matter. All these machines collect the information the same way, and you have to look at it. And I'm going to steal Mike's line on this, and he says if you're not looking at your data when it comes to patient treatments, then it's like swinging a baseball bat in the dark. So sure, you might make a contact every once in a while, but chances are you're going to miss on every opportunity that a ball comes towards you. So when you start looking at your data, that's what's going to drive your change. And the other thing I'll say is don't be scared to make change. If you look at your information, you look at your data, and you say that you're a lower performing service, contact the higher performing services. Ask them what they're doing, and they will share that. And if you're a higher performing service, share it for free. The only way our industry gets better, the only way we improve cardiac survivability or patient treatment is if we all share the positive experiences we're having and we recreate that over and over and over again. The reason why the top treatment in the world works is because everybody has that same information. And so if you're the best performing EMS provider, the best performing hospital, but you don't tell anybody about it and you don't help get anybody else better, then what is the value in being the best?
Right. And that's why, quite frankly, we bring you guys on here. I want the whole world to be exposed to you guys, to be quite honest with you. So thank you so much, Adam. Mike, take it away.
Yeah, the only thing I would say is that when you are reaching out to, and I guess, cardiac arrest is a team sport. And when you're reaching out to other agencies, you're going to your hospital, and you go with data, they're more likely to listen to you, right? And so that's exactly what we did. We said, hey, here's 4 patients that you accepted. And somewhere in the mix, the patient had a cardiac arrest, and all of a sudden you have you have caring, compassionate people that are looking at the data and going, yeah, let's make a change. And then all of a sudden things are a lot easier. So use your data to help build those relationships with other agencies, and I think sports teams are doing this. They're looking at their game tape and their analytics. You know, in basketball, 3 points is worth more than 2 points, and all you got to do is shoot 33% to be a 50% 2-point shooter. So a lot of those simple things are a lot easier for people to swallow when you bring your data to the party. So
excellent. Very well said. And I would encourage everybody. So this is the third in a series of, really hospital level cardiac arrest and resuscitation a type of processes. I would tell everyone, go back and listen to Jen Hayes. She perfected inpatient pediatric resuscitation using data. Then we had Garrick and Victoria, who fixed the emergency medicine adult cardiac arrest, where they found out that when they were actually measuring their compression rate and their depth in the recoil, they were only 2% of the time getting all three of those right, 2% of the time. And then after they did like a 6-month intervention, it only went up. I think it went to like from 2% to 14%, and then finally up to like 50%. And that's after, training and having a CPR coach. And now you're hearing Mike and Adam are doing the same exact thing from EMS now into the hospital. And so just watch those 3 webinars, and I think you get a very good idea of what some of your next steps are. Go to the conferences, meet the people, email, reach out, and don't think that you have to have the fire chief or your executive director's kind of nod, if you will. You could be a single person, make enough noise, and you can change your agency, you can change your community. And I hope that all of you do that. I hope all of you are inspired by the fact that EMS is the most important link in the chain of survival when it comes to cardiac arrest for kids and adults. You guys are the ones who fix these people, and then you pass them off to the hospital alive, and then hopefully that patient walks out of the hospital. So believe in yourselves, believe in your organization, believe in your community. Don't say that the doctors at the hospitals can do it better, because they don't. They 100%, like, if I could stand at the top of the mountain and tell people EMS saves lives, period, end of story. And let's own that. So with that, Mike and Adam, thank you guys so much for joining us today. You guys are so impressive. I can't wait to see you up in Calgary. And thanks everyone for joining and taking time out of your day. Get your CEUs, stay connected with us, and we have plenty of webinars. We're going to do these monthly and keep coming back at you. And Dan, thank you as always. You're the best.
Thank you, everybody.
Peter, appreciate it. Thank you.
Thanks so much, guys. Go Panthers, go.
Yes, go Panthers. Let's go.